Hello. Chúng ta bắt đầu cái phiên đầu tiên, cái phiên khai mạc. Chúng ta mời các anh chị chúng ta ổn định. Cái phiên khai mạc thì tôi cùng với giáo sư Hoa sẽ chairman cái phiên này. Cái bài đầu tiên tôi xin giới thiệu giáo sư ALEXANDRE KRAINIK từ Pháp sẽ trình bày cái bài về hình ảnh cấp cứu thần kinh ở người cao tuổi. I would like to introduce Professor ALEXANDRE KRAINIK from France. Professor ALEXANDRE KRAINIK was born in 1970 in Paris, France. He graduated from the medical school at the Piche Saint-Pétrier in Paris in 1993, and he completed his residency and his fellowships in radiology in Paris. In 1998 and 2002, respectively, he received his PhD in neuroscience from University and Marie Curie, Paris. After his postdoctoral work in Max Planck Institute of Brain Cognitive Neuroscience in Leipzig, Germany, he moved to Grenoble in France, one of the most innovative cities in the world. In 2009, he became full professor of radiology at the University of Grenoble, Antwerp, and further headed the Department of Neuroradiology and MRI and research platform in Grenoble University Hospital. He practices directed neuroradiology. His main science activities focus on functional imaging of the brain with critical application, and he published about 130 original scientific articles and presented over 200 scientific publications in international congress. His teaching activities are dedicated in basis of MRI techniques using diagnostic neuroradiology. And he gave about 140 lectures in national and international meetings. Professor KRAINIK was president of French Society of Neuroradiology. He is now vice president of French Society of Radiology, in charge of international affairs and member of the Diagnostics Committees of Europe, European Society of Neuroradiology. Professor KRAINIK, please.
Well, thank you very much for this kind of introduction. And it's always an honor to be invited in Vietnam, and I feel always very moved as far as I see and I hear to people speaking so well French. Well, this talk going to be in English, no advanced imaging, but daily practice, considering all the neurological emergency in elderly. Then, well, few key points in elderly. Neuro, it's about 10% of the emergency. All emergency are similar to adults, whatever stroke, trauma, and so ever. Actually, there are a few differences considering elderly when you compare to adults. Let's say the lifestyle is quite a bit different. There are usually less sports or less drug abuse. And there's also part of, in our Western society, a part of loneliness, which usually can delay some diagnosis. There's also multiple risk factors. Usually there's a general and cognitive weakness, whether gait disturbance, there's any kind of neurodegeneration, and so on. So usually our multiple disease and undergo several treatment. So there's a very high risk for falls in their daily life. Usually the history can be unclear and the symptoms can be quite poor. For instance, it's usually a very non-specific confusion, and the fever is in constants, including in infectious disease. Finally, there's a very high prevalence of hemorrhagic lesion, whether ancient or recent accident. And as the treatment as is proved, aging is less a limitation in care management now. then actually there are few facts that may change things in aging. First, there's a brain atrophy. Well, brain atrophy, we know that it concerns, include everybody after, let's say, 30 years old. And in a certain way, it can be an advantage, especially when you have a mass into the skull, because all this brain atrophy is replaced by CSF, then can soften the mass effect. Then the subarachnoid space are enlarged, and it's quite common. Ventricles are usually enlarged as well. So in a certain way, the subarachnoid space are kind of elastic compartments that may buffer intracranial hypertension. Here is typical enlargement of the CSF that can be observed, and sometimes you have to distinguish this enlargement from CSF from true subarachnoid hemorrhage. The fact is that when you have enlarged subarachnoid space, when the brain shakes because of movement and so on, it may lead to venous shearing and a higher incidence of subarachnoid hemorrhage or subdural hematoma or even cerebral venous thrombosis. Second, there is a fusion of the external leaf of the dura with the skull. And then it means that the extradural hematoma is absolutely exceptional over 60. It's almost, there are very, very few. Others are very common calcifications that shouldn't be misunderstood with pathological disease that could be observed in a younger patient. Well, you have to know them. Don't get confused with hemorrhage. And of course, there's a lot, and it's very common in elderly to have previous lesion, whether history of stroke, trauma, even tumor. Then you have to be very familiar with the patient history. And it's one of the most common mistakes we do, whether we do reading or teleradiology. You have really to look for all the medical data available, whether on PACS or medical records and so on, and as possible, try to meet the patient when it's possible, or even the clinician, to really clarify what happened in the patient's life. Well, now we'll try to overview a little bit what kind of lesion we may observe in elderly. Of course, trauma. Well, here's a case of a patient having stair fall under direct oral anticoagulation, and you see the importance of the hemorrhage into the brain. The topography is very similar as usually with the temporal area, the frontal area, orbitofrontal area. This is not specific. It's only the risk of hemorrhage is higher, especially when those patients have this anticoagulation or even under antiplatelets. Here is another case, a patient referred for head trauma. You can clearly see here there's probably a subdural hematoma associated with subarachnoid hemorrhage, but well, when you have a trauma, you have to always look for the bruise, and you see the bruise is here, and then you have to look carefully to the bone to see the fracture. Then it's a general principle. 3D imaging can be helpful to better identify the fractures that sometimes is quite tricky to observe. This is not a very specific point of elderly, but the fact that the symptom can be quite mild, and the Cron-to-Crew contusion is very common. Again, here is a patient referred for a head trauma, and you see several lesions. You first have here an hematoma in parietal area. Here you have a hypointensity in this region. You really have to really get the patient history. Of course, when you look at the image, you look at the bruise, you see the fractures, and when you get the family the patient history, he had a stroke sequelae. Then it's important not being confused with between old and sequelae, old lesion and sequelae with recent. One interesting point, referring to what I mentioned, as the dura fused with the skull over age. You see here you have a fracture and despite the fracture, you have no epidural hematoma. So there's immediately here contusion and subarachnoid hemorrhage, and possibly include a very small subdural hematoma. Of course, all those patients may have previous hematoma. Here you see a chronic subdural hematoma with a rebleeding inside. And the fact is that when you look carefully, is there any mass effect despite the side of this hematoma? When you really carefully look around the midbrain, there is no herniations. And as I say, the atrophy, the brain atrophy, in a certain way buffer as a mass effect by the different lesion, including trauma. Here is a similar case, except that sometimes the mass effect can be huge. And here you see, don't get confused. All this is bleeding. Fresh blood, despite the density, is quite low. This may happen in patients with anemia. And you see there's very large mass effect, but well, sometimes the mass effect is so important, and you have this transentorial herniation with possible coma because of the mass effect on the midbrain. This is a small sign which is not so well known. Maybe people doing pediatrics are more familiar with this kind of lesion. As I mentioned, the enlargement of the subarachnoid space in a certain way favors the shearing of the veins, and especially the cortical veins. And here you see a small hemorrhage. Commonly it's referred as a subarachnoid hemorrhage. In case here you have some subarachnoid hemorrhage, but here you have a true venous occlusion. It's only a venous shearing because of the brain shaking, and it's referred in pediatric as a tadpole sign. I don't know if you're familiar with the tadpole sign, but in pediatrics, it's also quite common to see this little cortical vein thrombosis in children, even and when you have also a chronic subdural hematoma in this case. You can suggest this misabuse here as referred as a tadpole sign. You see tadpole here, and it's also a kind of sign or suggest a shaken baby syndrome. But it's exactly the same in elderly. As the brain atrophy goes on, the subarachnoid space enlarge, and it's easier to shear the veins. Here another example, and when you have a look at it, you recognize them very frequently. It's a quite common sign. Actually, it's not a matter of prognosis. There's no extent in the main dural sinus, but it shouldn't be confused with or missed with subarachnoid hemorrhage. It can be associated as well. Here, the fact is that sometimes it can be quite tricky. The clinical history is not always so good. Then this patient was referred for a head trauma, and he had a confusion. You look, head trauma, you look for a facial trauma. We mentioned there was a nasal bone fracture, but of course you always have to be systematic and look everywhere, and you'll see the fracture of C2 here. Then don't be mixed up, because it's very common, all those associated lesion in patient having in the elderly, and of course all this condition. Here is a fusion of the vertebra that favor the fractures of the bone. In stroke, well, what should we say different from elderly to the adult? Actually, in elderly, the problem in ischemic stroke is especially the risk of hemorrhage. It's not exactly the mass effect, because I say that the brain atrophy buffer the increase of the edema, but the fact there's a higher risk of hemorrhage, and you see it's quite common to see here in an infarct of the posterior cerebral artery that it turns into hemorrhage. It's nicely demonstrated here on SWI or T2 star. Then here is another, it's not specific but much more common in the elderly, in patient referred for chronic high blood pressure to soothe this deep brain hematoma, especially here in the thalami, or it can be internal or external to the putamen. Here just to show you, okay, it looks like an hemorrhage. It's heterogeneous, but remember that hemorrhage at the early phase can have a really low ADC and sometimes may mimic in a certain way roughly some ischemia. But of course, T2 star don't mix you up, because here you see all the hypointensity related to the acute hemorrhage. And here then you see all these elements are in favor of small cerebral artery disease related to chronic high blood pressure, and in a certain way to demonstrate this risk of deep brain hemorrhage, you look at SWI, and you may find some small microbleeds, mostly in the deeper area of the brain. You see here into the thalami, into the putamen, and this has to be distinguished from the microbleeds that are observed in the cortex on the periphery of the brain. Sometimes it can be associated, but it's a different conditions that having microbleeds in the deeper area, where you see you have a risk of hemorrhage in deep brain area related to chronic hypertension, and doesn't require any specific management of anticoagulation. Then those that can be observed with a superficial microbleeds. And of course, those hemorrhage can be absolutely dramatic. You see here a massive hemorrhage that are more seen in elderly. This deep brain hemorrhage has to be distinguished from lobar hematoma. You see here, and of course you have to exclude all vascular disease, all microvascular disease, such as aneurysm, well, usually not here, but like arteriovenous malformation, arteriovenous fistula, or even infectious aneurysm. Of course, you have to exclude all cerebral venous thrombosis, but once you've done this, you have to look for tumors, and that's why MRI is requested. And you also have to look for cerebral amyloid angiopathy. Of course, cavernoma can be excluded this way, but usually they are symptomatic a bit earlier, at 76, when you have some history of neurological symptoms. You have to suggest the possibility to have a cerebral amyloid angiopathy, and it's nicely demonstrated using MRI, and especially susceptibility weighted image that can show first the sequelae of hematoma, second some numerous microbleeds that are located on the superficial part in the gray matter, in the cortical gray matter, not in the deep brain area, and you can also have meningeal siderosis elsewhere. With all this, you have 3 hemorrhagic signs, plus the age, plus the symptoms, making the diagnosis of cerebral amyloid angiopathy highly probable. So the fact is that when you diagnose or when you suggest the possibility of having cerebral amyloid angiopathy, the fact is that there's a contraindication to anticoagulation. And the first thing you have to do when you see such a case is to go to the patient or his doctor, ask whether he has some anticoagulation. And when he has some, this anticoagulation has to be really discussed and to see if it could be find an alternative to this treatment, because then there's a very high risk of hemorrhage and especially hematoma recurrence. Here, of course, sometimes it can be tricky. Here you have an isolated lobar hematoma, CT referred for a patient referred as stroke. Here you see flare, T2 stars, there's no big deal, it's hematoma. But, well, this is T1, and this is post-contrast T1. And when you look carefully, it seems there is some enhancement on the periphery. Well, there was a suspicion of underlying tumor. The PET was normal, then it was not metastasis. And finally, on the follow-up, we saw that the tumor grows very much. You see there's some contrast enhancement of the periphery. Actually, it was a glioblastoma. So of course, MR has to be performed each time you don't have any clear microvascular cause of hemorrhage. Epilepsy, just briefly, then in the evaluation of first seizure, most of the time we are looking for bleeding or bleeding history, because bleeding is the first cause of any seizure in the elderly. Despite we're looking for tumors, we always mostly find bleeding. It can be related to chronic subdural hemorrhage, can even have rebleeding, or here is a chronic subdural hemorrhage. But the fact is that we're looking for tumors most of the time, and that's what we have in mind. It can be a primary tumor, a secondary tumor. Here's a glioblastoma, here's a MET, here's a lymphoma that can also be revealed sometimes with epilepsy, and here's a very large meningioma. All those diseases are very common in the elderly. But here, for instance, it's a patient referred for a seizure with a history of breast cancer, and you see a little hemorrhage with edema, and when you do the examination after injection, you see additional lesion that enhance. And not all sequence are related, all lesions are related to hemorrhage, but it's very common to have hemorrhagic metastatic related to breast, kidney, thyroid, melanoma, and so on. Then each time you have to investigate seizure in adult, always perform CT or MR with contrast. And of course, this is the most common cause of epilepsy, history of stroke that may turn into small hemorrhage. You see all those little hemorrhagic lesions are one of the most significant elements to elicit stroke, to elicit seizure. Okay, just to finish very briefly, to be sure you're familiar with this kind of diagnosis. It's a patient referred for diabetes, and he has some right abnormal movement for 4 days. You see on CT maybe some increased density of the left basal ganglia. On MR, you see on T1 this hyperintensity on T1 of the Putman. And then you have to suggest the diagnosis of hyperglycemic hemichorea without ketosis. And then one of the most common blood sample testing is to look for hyperglycemia. And finally here, I'll finish with this. It's a patient referred for gait and behavioral disturbance with worsening 2 weeks. Now there's a nystagmus, and when you look on FLAIR, you can hardly see things, but when you look carefully, maybe a cortical hyperintensity here, cortical hyperintensity in this area, and cortical with a low ADC in this way. And when you look carefully, there's also a decrease of the ADC in the basal ganglia. Of course, you recognize a Creutzfeldt-Jakob disease, another disease which is much more common in elderly. Just to take home message, remember that with normal aging, the brain is atrophic. You have enlarged subarachnoid space, and there's a sorry, is miss, sorry, it's in French. Didn't take the right file. Then this frequent venous lesion, epidural hematoma are exceptional. You have to look for patient history to better clarify the different lesion into the brain. And of course, there are numerous lesions altogether. Again, remember, you really have to remember there's a lot of stroke mimics. When you go for epilepsy, you have to perform examination with injection. And when you look for hematoma, you always have to look, especially for microvascular and macrovascular cause, including MRI, to identify different lesions that may contraindict anticoagulation. I thank you very much for your attention.
Thank you, Professor Alexandre for the very interesting lecture. So we should have a question, but it's the end of the session. Yes.
Vừa rồi chúng ta nghe một cái bài báo cáo rất là thú vị, bởi vì nhấn mạnh chúng ta vẫn những vấn đề khác biệt giữa bệnh lý của người già và người trẻ trên cùng một loại chứng bệnh. Thì chúng tôi cho bài này rất là hay, và chúng ta cần phải suy nghĩ trong cái chẩn đoán và theo dõi trên hình ảnh, nhất là những cái bệnh lý của người già trong stroke, trong chấn thương. Thì chúng tôi nghĩ là cái bài rất là hay. Thank you. Okay, the next topic is